Hello everyone and welcome to the video presentation series titled Blood Clots. The work is catered to the MRCS candidates whom I find is helpful in revising their exams. There is no conflict of interests and all videos were made for educational purposes only. This is the list of the learning objectives that we will be covering today, so please enjoy. The definition of clots, thrombus and embolus are distinctive from each other. A clot is a solid material formed from the constituents of blood when the flow is stationary, whereas a thrombus is a solid material formed from the constituents of blood that is flowing. An embolus can be a clot, thrombus, or other materials which has traveled from point A to point B in the bloodstream. A few examples of the emboli are thrombus, fat, air, amniotic fluid, atheroma, tumor cells, and even foreign body such as a tiny surgical instrument that has dislodged into the bloodstream, which can cause an embolus. Virchow's triad describes the three critical interrelated components required for venous thrombosis. They are endothelial injury, which can be caused by the trauma, surgery, or even catheter, such as a PICC line, acquired or congenital hypercoagulability, and stasis of blood flow due to immobility or polycythemia, which can also contribute to the endothelial injury. Deep vein thrombosis, DVT, and pulmonary embolism are manifestations of the same pathological entity called venous thromboembolism. The risk factors of VTE can be generally divided into patient, diseases, or surgically related factors. Patient factors of VTE include increasing age, immobility, pregnancy, oral contraceptive pills, and smoking. Thrombophilia conditions such as congenital protein CNS and factor V Leiden deficiency will also predispose patients to venous thromboembolism. Trauma and surgery can cause VTE for reasons such as the vessel wall damage, blood loss, dehydration, as well as immobility. Diseases that predispose patients to VTE are malignancy and polycythemia, IBD, and nephrotic syndrome are a few examples of prothrombotic conditions that increase the risk of developing a VTE. On the other hand, congestive heart failure increases the risk of VTE due to the reduced blood flow. We then now look into the VTE prevention strategies, which can be broadly categorized into mechanical, like TATS stocking, which stands for thromboembolic deterrent stockings, or a pneumatic calf compression, also widely known as Flowtron boots, and pharmacological prophylaxis such as low molecular weight heparin or a direct oral anticoagulate agent. The timing of VTE prevention strategies can be best divided into pre-op, intra-op, and post-op, respectively. Few of the common pre-op measures like TATS, heparin, good hydration, early mobilization, and stopping of prothrombotic drugs and appropriate timing, for example, an oral contraceptive pills or a hormonal replacement therapy, can be stopped 6 weeks before the surgery. Intraoperative strategies are similar, but mainly the focus will be more on correct patient positioning to avoid pressure areas during the surgery and aim to reduce the duration of the surgery to a minimum. Lastly, neuroaxial anesthesia during the surgery can reduce immobility post-op, as well as the benefits of topping up as analgesia after the surgery, which would then enhance the patient's recovery by encouraging mobility. Again, post-op strategy will include DVT prophylactic measure and aims to achieve early mobility as part of the ERAS protocol, which stands for Enhanced Recovery After the Surgery. Now, let's take a look at the arterial component of the vessel disease. Before that, it is beneficial to understand a little bit about cardiovascular system physiology of blood flow. Generally, blood flow is laminar in the body under normal circumstances. However, under the high flow conditions, particularly in the region of ascending aorta, laminar flow can sometimes be disrupted and become turbulent. When this occurs, blood does not flow linearly and smoothly in adjacent layers, but instead the flow can be described as being chaotic. Turbulent blood flow is also seen in large arterial branching points in diseased and stenotic arteries, and across a stenotic heart valve as the murmur we heard during cardiac auscultation. Turbulence itself does not begin until the velocity of flow becomes high enough that the laminar flow breaks apart. Therefore, there is actually no gradual increase in turbulence as blood velocity increases in the blood vessels or across a heart valve. Instead, turbulence occurs when the critical Reynolds number is exceeded. Reynolds number is a way to predict onset of turbulence under ideal conditions as shown in the diagram. It increases as velocity increases and decreases as viscosity increases according to the equation. Therefore, high velocities and low blood viscosity, as within the case of anemia due to reduced hematocrit, are more likely to cause turbulence than the normal blood. We then now move on to the different terminologies in describing arterial disease. Atherogenesis is the process of forming plaques in the tunica intima of the artery. An atheroma is a reversible accumulation of degenerative tissue in the intimal layer of the arterial wall. Atherosclerosis is a chronic inflammation and disease of the tunica intima due to atheromatous plaque, which is reversible upon reversing and modifying the risk factors together with secondary prevention strategies. Whereas arterial sclerosis and arteriolosclerosis describe the hardening and loss of elasticity of large to medium arteries and arterioles, respectively. This is an illustration of pathogenesis of arteriosclerosis ranging from the initial lesion of the intimal wall by macrophage and foam cells, as well as intracellular accumulation lipid forming fatty streak starting in the first decade. The initial lesion and fatty streak are clinically silent. Continued intracellular lipid accumulation will eventually form extracellular lipid pools, which is now visible under the microscope, which contributes to the formation of atheroma. Fibroatheroma is essentially an atheroma covered with increased layers of smooth muscle and collagen. Fibroatheroma can be clinically overt or silent around from the fourth decade. The lesion can be complicated by surface defects of the fibroatheroma, which can then cause bleeding into the plaque and hematoma. This will slowly but surely reduce the vessel wall diameter and disrupts the laminar flow of the blood, and thrombosis will ensue, causing presentations such as acute coronary syndrome or stroke depends on the location of the atherosclerosis. The complications of atherosclerosis includes calcification, aneurysm formation, plaque ulceration or rupture, hemorrhage into the plug, thrombosis, embolism, and lastly, vessel occlusion and ischemia. Included a few slides on the summary table of coagulation cascade clotting factors, as well as a few examples of iatrogenic and genetic causes of coagulation disorder. Last but not least, von Willebrand disease is the commonest coagulation disorder that prolongs the APTT and bleeding time, whereas hemophilia A and B are the X-linked autosomal recessive mutation, causing the factor 8 and 9 deficiency. Hence, it is commoner in male and usually it prolongs the APTT only. We have reached the end of the video presentation of blood clots, and the next topic of the discussion will be about limb ischemia. Thank you very much and till next time.